So I am delighted to introduce Dr. Robert Slocum. He is Narrative Medicine Program Coordinator at the University of Kentucky Healthcare in Lexington, Kentucky. Dr. Slocum holds doctorates in law from Vanderbilt, ministry from University of the South, and theology from Marquette. He has experience in pastoral ministry as well as academic teaching and administration. He has taught undergrad courses in religious studies and ethics. He's currently appointed as assistant professor within the voluntary faculty title series at the Department of Internal Medicine of the University of Kentucky College of Medicine. He teaches fourth-year medical students an elective on narrative basis for patient care and resilient practice. He is a member of the Hospital Ethics Committee. He's an author, editor, co-editor of 14 books, including a Journal of Reflections. He's also published short fiction and poetry. He's interested in the clinical application of narrative and the significance of narrative for identity formation. Welcome, Dr. Slocum.
Thank you very much. Can you hear me okay? The voice is good. Okay. So just to say, I would like to give a basic overview of narrative. I realize many of you are quite familiar with it already, but I'm just going to give our approach to it and then to allow some questions. I can see this is a very interactive group and want to allow for that. I'd also like to have time, I hope I will, to describe the development and evolution of narrative medicine at University of Kentucky. This is the first such program here. It's the first such program in our part of the world that I'm aware of, and just the steps we've gone through to make this available might also be of interest to you. But first, what it is, and then how it is. We'll approach it in that way. And as I say, I want to make sure we have time for questions. But I did submit slides, and so I'm going to let that loosely shape what I'm talking about. But I want to say, first of all, that stories are at the heart of it. Stories, if I were to tell you about key events in my life that are complicated and perhaps spread out over a period of time. My first year in graduate school, when my wife and I met, or when we moved to a new state, all those things, but it would constellate as a story, would be reframed as a story. As I look back on it, it would be engaged as a story. I think it's Kierkegaard who says we live our lives forward and understand them backward. And so as we reflect back, we may come to moments of insight and understanding. So just to speak of narrative as an expression, I'm going to scroll along to as an expression of medical humanities, which will come up shortly, just to say that there are many ways of knowing, kind of in terms of epistemology or ways of knowing, and different ways are more helpful in different situations. I mean, so I'm a strong believer in science and scientific method and proof, but there are other ways of knowing as well that we may find very helpful. So this way of understanding ourselves as shaped by our stories, engaging our identity through our stories, and indeed working through the situations we face by means of stories. And the story not only subjectively known, but as shared. So as Rita Charon, for example, talks about the dyadic relationship that can take place in a narrative medicine context between the one who tells and the one who listens. And just to say then, narrative medicine is not simply active listening with compassionate presence, although it certainly includes that, but rather a dynamic interaction of two people or more in certain contexts, whereby the story can be told, it can be reframed, the teller may be surprised by what comes up, carefully posed questions may guide the conversation, lead to new insights. So it has a considerable potential for healing, for growth, then again, we can say fundamental truths about a story can carry over so that we can identify characters, plot, motivation, obstacles, conflict, resolutions in the story itself. And that can be a very helpful aspect of it. And of course, therapeutically speaking, to help the patient claim their own focal role as the main character in their own story. Sometimes, unfortunately, people may find themselves displaced in their own story, that the central character has become a provider or another person who's giving direction, and to help them to regain their proper place in their own story. Listen is at the heart. I mean, in my own spiritual tradition, in the rule of Saint Benedict, the first word in the rule is listen. And listen itself suggests a way of life that reminds that I don't have all the answers. I need from beyond me what I need to know. Listening to another conveys respect, that their words are worthy of hearing, that I don't know what they're going to say before they say it. They might say something important. They might say something surprising. So the role of listening, as mentioned, I've had some work with medical students, and I think it's a very important thing to say that engaging the next generation of medical providers to be oriented to listen, to not talk over, to make room for the other and what they may have to say. So the patient, as the patient can share their story, may have their own moments of discovery and also lead their team to insights about the patient, their goals of care, their character, their strengths, weaknesses, what they bring to the situation. As I'll mention in other contexts, this is an ancient practice. I mean, there's some that said, well, this started in the 1990s. Well, by the name narrative medicine, yes, it did start in the 1990s, but the hearing out of a person who is in need of healing, to understand their context, their situation, their life stresses, their sources of strength, is an ancient practice, and one that we do well to respect and to carry forward. So again, drawing out the patient's role, helping them to engage fully in what it is that they're facing. So again, moving forward, narrative medicine is patient-centered, interactive, and dynamic. It is not formalized. It's not standardized. I've had visits in which I went in confident I'll be talking about one topic, and another was precisely what happened, and I was glad to go with that. I remember once visiting a patient in our oncology infusion clinic, assuming that this patient, first time infusion patient, would be talking about their cancer or maybe anxiety about chemotherapy. And the person was really pretty confident about all that, but their spouse, their husband, had died unexpectedly 6 months previously. So we spent the time dealing with her grief. That was completely different from what I imagined the session would be like. But that was where the heat was, so to speak. That was where the conversation needed to go. So again, it's a collaboration that is very important between the provider and the one being healed. I have a quote here from Mary Shannon about the physician's use of self. I'd say the provider's use of self, attention, compassion, presence, space, close but not too close, giving room for the patient, giving guidance, appropriate questions, and yet letting the patient's concern, the patient's timing. I frequently say to a patient, because since we are able to offer both inpatient and outpatient visits in narrative medicine, there's no rush. I say many of the patients I speak to have perhaps encountered a trauma or facing a traumatic health crisis, but to say we don't have to talk about it all in once. We can go at your pace, and to allow space for that, allow room for that. Sometimes I like to say they're the inefficient efficiencies. If we cut off the patient too soon, what we didn't ask, the question we didn't ask, may prove very harmful. We may be surprised by it. So engaging patient stories that they may perceive their lives, treatment, and whole situation in terms of their stories, and be very glad for the opportunity to share that, to claim their role. Arthur Frank describes types of patient stories in terms of restitution, chaos, and quest. Of course, narrative by its own nature invites the patient to a kind of quest. As Carl Miniger said, to come to a place that's weller than well, better than well, that the occasion of their illness, which may be, or injury, which may in itself be traumatic, may set in motion processes that lead them to new levels of differentiation, integration, self-awareness, that perhaps might never have happened for them, or not happen for a period of time. I've spoken with patients and said, just hypothetically, would you want to go back to the life you were living before? And they say, no. I mean, I would never want the illness or injury to have happened, of course, but I never want to give up the insights, the gains that I've made through this process. Sometimes it's as if the injury or illness itself has been a reminder to slow down, or to reclaim their true priorities. So that's a very important aspect of what can happen through narrative medicine. Over time, I evolved 4 core questions that at times may be more implicit than explicit, but still, just to mention what brings you here, what helps you the most, do you see anything differently, and what comes next? Now, again, this would be more for a first-time visit. In longer-term patients, those questions have been folded into ongoing dialogues, but still, the importance of those questions is significant. The idea of framing or reframing the context, even before going into detail on the questions, just to say, it may be possible in the reframing to, for instance, distinguish pain and suffering, which I urge are not synonymous. That we may have pain that isn't necessarily connected, perceived as suffering. My wife, when she went through childbirth without anesthesia, I'm sure there was pain, but her memory of that experience is one of great joy. So it was not for her a time of suffering. I can give an example of myself of an athletic event that it involved some pain, but it was like a victory. It was an occasion. It was an opportunity. And so that was not an occasion of suffering. Conversely, there could be suffering without physical pain. I'll speak more later of the work of Dr. Viktor Frankl, a German Jewish psychiatrist arrested by the Nazis, who survived a concentration camp. One of the stories he tells from that is of a time when he had paused briefly from his labors, and a guard threw a dirt clod at him. He found that to be a demeaning, hurtful experience. The clod didn't physically hurt him, but he felt demeaned by it. So just to say that there may be times of suffering without pain, and pain without suffering. And so that distinction can be drawn out, among other things, in terms of the questions that we ask. He found that experience that I described in other aspects of it to be dehumanizing, to be in a place where his identity was overlooked or intentionally ignored. There was no place for dignity. His autonomy was stripped. Relationships were severed, not treated with respect. But just to say, at times, and for the best of reasons, our own care of hospitalized patients may do some of the same things. They may be given a number. They may lose their autonomy necessarily, and for good reasons at times, because I mean, they can't just get up and walk to the bathroom because they're dizzy because of the medication they're receiving, but still it's a limitation that may be perceived as painful. In a pandemic, maybe their relationships, they can't have visits from family, or if they're on the bone marrow transplant ward, young people can't come to them for fear of spreading a disease. So just to say, there are aspects of treatment that may be dehumanizing, but listening, engaging their stories, hearing them out can conversely be a humanizing experience for the patient, that they are respected, that their quest for meaning, their renegotiation of meaning is honored, supported, even stimulated, given catalyst. So again, in terms of the questions, what brings you here invites the whole story of symptoms, the shock, maybe the floor has seemed to fall out from under the patient with an unexpected diagnosis of a severe condition. But just to say that helps you the most. The sources of strength, sometimes to ask the question, what helps, and it puts on the front burner sources of strength that may have been more implicit. And moving on to the next one. Do you see anything differently that invites the change of perspective that may have come with treatment? One of the aspects of the service at UK, and this may be of particular interest to this group, is on Mondays and Thursdays, I do a half hour to an hour long journal workshop group with patients in the behavioral health unit. These are short-term patients, oftentimes 3 to 5 days, but a question that I'll frequently ask after discussion of the journal prompt and the patient's writing is just, in the time that they've been here, which is sometimes brief, but if they come to see anything differently, have they come to differences, different priorities, or even just finding others with similar conditions, others that they may be able to trust or hear out, does that make a difference in perspective? And then finally, of course, what comes next? A future orientation. Again, Frankel found that those prisoners who had a future orientation relative to what he came to term logotherapy did better, didn't run into the electric wires, didn't give up. Just maybe one prisoner was hoping to finish a multi-volume writing work. Well, if you give up, there'll be no one but you that can write that book. Another just simply wanted to be reunited with his daughter. Well, if you give up, you'll never see her again. Well, that was motivating. It helped to move them forward in an unspeakably difficult time. So just to say, engaging the future, the hope of the patient can be critical in these settings. Other options, possibilities, follow-up visits, life review, journal workshop, journal writing. In some cases, I'm able to invite patients to journal between sessions. They can come back and review what they've written, to write down perhaps dreams that have come to them or other clues that may be helpful in our discussion. The life review can be an extremis, it can just be bringing up to that time. That really just to move forward from there, just the journal workshop, giving an opportunity they could interact with one another as well as the facilitator. Just in passing, that narrative ethics, kind of viewing the questions, the choices that must be made narratively. Which story best accounts for the decisions that must be made? Does the story seem to have something missing? Is there a question that needs to be answered before a decision can be made? So again, that's another aspect of the work. And then just to say, renegotiating identity is such an important aspect. As Lexington talks about, the biographical disruption that comes with illness or injury. It may be necessary. The patient may have outgrown an older self-concept that needs to be reconsidered. And narrative can help with that as they describe their unfolding self and understanding. And then just in a kind of summary, of course, reaching back to the 1920s, Dr. Francis Peabody, patient care begins with care for the patient. So to help the patient engage that care, to help the provider provide that care, to help the provider also to be connected with the part of them that seeks to serve in that way, to not become detached from it in a way that will interfere, that will sort of veil them from their truest self. Again, as with Dr. Mel's Madroma, that the tradition of this is not something we've just discovered. It's something that we re-engage again and again for the sake of the patient. These ideas to discover new meanings where the old meanings don't work anymore. That can go both in terms of the worsening situation of a newly diagnosed or injured patient, but even in the adjustment process of recovery. Sometimes that may be even more challenging for the patient to once again step forward, to take risk, to engage, to risk failure after a time when they've been away from those contexts. So that too, the recovery phase may also engage narratively in a particular kind of way.